Hello, can you hear me? Hi, good morning. Yeah, I was waiting for everyone to join. Sorry, we are late by 7 minutes, but I will give you this much time. So, how are you? Yeah, I'm fine too. So, how is your morale? That's good. Stay positive, work hard, work in the right direction, and you should be getting the right results. Don't worry at all. So, today I think we should cover menopause, then this PID, and then I will see that what else we can do today. Hello, Assalamu alaikum. Yes, doctor, how are you? I'm fine too, thank you. So we will try to cover, and then I want to go back to the questions because before we start, you know that we have to do this OB mock exam. I think on 9th. That should be on Friday. So before that, we have to cover the questions also. Uh, the exam for the last exam we had. Okay. So, so do you know that what is the news related to menopause? Do you follow any news, any search engine, anything? Okay. BBC said that they have done some research in this UK, and they are saying that they have developed confirmed methods to delay menopause for another 20 years. So in selected cases where people they couldn't have children, then they will try to prolong. They have set up certain criteria. Still legislation is being done, so no ruling so far. But in the scientists they are saying that they have developed the methods and they are going to delay menopause to for 20 years, by 20 years, so they can females they will be able to have children till the age of 70. So, but as you know that if the egg stays in the dormant phase for such a long period, there are going to be certain problems. Even when people are conceiving in their 40s, you are familiar with all of the problems that what will happen. Placental issues, congenital anomalies, miscarriages, antepartum hemorrhage, aneuploidies. As such, no congenital anomalies, but the risk of aneuploidies will increase, so they are going to have full-fledged syndromes. And then ethical questions are there that what is the average human life expectancy? Even in the first world, it is like 70 years. So you just can't have kids and then leave them to at, at the mercy of others and then go back. That's not appropriate. So anyhow, they have developed and they said that this is costly, but I think that it's not so costly because it is going to cost around £6,000. So if they can buy time, then nothing like it. So, but I don't know that what do people have in their mind. But this issue has been going on for quite some time. That people have been delaying this childbearing before like 30 years. The average age of for the first delivery was like 26 years, and in 3 decades it has increased to 29 and a half years. So we don't know that, but the basic problem is that people are not, I'm talking about the Western world, people are not in stable relationships. They don't find suitable partners, and actually they ask these questions in the MRCOG exam also. That what are the causes of delayed childbearing? So it was one of the things that they don't have social support system, they are not in a stable relationship, and they don't have the right partner. So that's how the things are going on. Anyhow, so in the exam, you should expect to get like at least 3 questions on menopause. So it's not exhausting, it's a short topic. So just remember the basic things. You should have a clear concept, and then you should be fine and you can choose the answers very quickly. So, how do we define menopause? I think the other day we were doing some questions, then I told you about that. Any one of you? So, what is menopause? Mm-hmm. Okay. and she will define with relevance to age. Okay, if the woman is 50 or more than 50, then cessation of menstruation for 12 months after the last, yeah, for 12 months she had her last period 1 year ago. And if she is less than 50, then what will be your definition? Okay, no problem. Yeah, yeah, excellent. Yes, 2 years. Then you will say cessation of menstruation for 2 years or 24 months. That is the thing. So, what do you think? What issues they are going to have? Yeah. So, what type of, yeah. So, how many different types of estrogen receptors we have? These are the types, but how many receptors? Alpha, alpha 1, alpha 2, right? Like that. So, where are these receptors located? Yeah, in the breast, there are estrogen receptors. They are on endometrium, in the joints, yeah, in the ovaries, and then in the brain. So, what do you think? What is the underlying pathology in vasomotor symptoms? Okay, then these receptors in the brain, in the midbrain actually, they are controlled by they are activated by estrogen. Okay, so they have a role in regulating the human temperature, mood, like that. So, what happens in the postmenopausal women? These are basically oxytocin receptors, alkaloid then there's opioid receptors. So, what happens uh, with passage of time? They become resistant to the actions of estrogen, and as the number of amount of estrogen decreases, so these are not very responsive. So as a result, your patient will have irregularities with the maintenance of the core temperature. So it is not the external temperature. This is about related to the core temperature. So what happens? First, she will feel very hot, and then what will happen? She will have this sweating, and then the temperature it will drop by half degree centigrade. So then again she will feel like hot, then again blood vessels will open up, and what will happen is the body will try to decrease this temperature. So just imagine that this temperature is very important, and you can see that by fluctuation of just half degree centigrade, how many problems she can have. So if you have to give her advice on lifestyle, what will you like to tell a menopausal woman? Hmm. So if she has vasomotor symptoms, we are going to tell her that she should wear layered dress. Like she should wear a light jacket, a t-shirt, shirt, and so that when she is feeling hot, she should remove her jacket, and when she is feeling cold, she should put it on. So you can understand that it is going to disrupt her quality of life. So then, what will you tell her? That if you after how much time she should expect that these symptoms will be relieved? She will have better body temperature maintenance, and she will feel better. How much time it will take to settle down? It takes like 5 years, okay? Takes like 5 years like that. So you have to tell them, yeah, this is that 2 to 5 years. That is the average range, because everyone is not going to have the same thing at the same time. So and then you might have noticed that in menopause, females they will have hormonal issues, and then like I told you that they will have problems in the joint also, especially in the knee joint. That's why the joint pains are more common in the postmenopausal period. Okay, so do you think that we need to do some lab test to diagnose it, or we will diagnose on the basis of clinical presentation? Yeah, that's right. So we are going to follow a NICE guideline on menopause. So basically, it is telling you about the diagnosis of perimenopause and menopause. So the recommendation is that diagnose the following without lab test in otherwise healthy women aged over 45 years with menopausal symptoms. So perimenopause based on vasomotor symptoms and irregular periods. Then menopause in women who have not had a period for the last for at least 12 months and they are not using hormonal contraception. This is also, you have to read the full sentence, that is she taking HRT or she is not taking, because they will have symptoms even before actual menopause, so sometimes they will be on HRT. So menopause based on symptoms in women without a uterus. So these are the three presentations. Take into account that it can be difficult to diagnose menopause in women who are taking hormonal treatments, for example, for the treatment of heavy periods. Do not choose the following lab tests and imaging tests to diagnose perimenopause or menopause in women aged over 45 years. Anti-Mullerian hormone, which are going to tell you about ovarian reserve, but you will have to test them if the patient is like in higher at 40 or 40 plus, when she is seeking treatment of infertility. Inhibin A, inhibin B, both are coming from the ovaries, and estradiol. Antral follicle count, again, we will do in cases of subfertility to see the ovarian reserve. Then ovarian volume. Where do we estimate the ovarian volume? In PCOS. So for the diagnosis, what should be the ovarian volume? Any one of you. 10 cubic centimeter. 10 cubic. No problem. You don't have to say sorry because random questions. 10 cm 3. That should be the volume. So don't use a serum follicle stimulating hormone test to diagnose menopause in women using combined estrogen and progesterone contraception or high dose progesterone. Consider using a FSH test to diagnose menopause only in women aged 40 to 45 years with menopausal symptoms, including a change in their menstrual cycle. In women aged under 40 years in whom menopause is suspected. So, if they are having it before 45, then we will say that she is having early menopause. So, what information and advice you should provide to patient and her relatives? You need to give them an explanation of the stages of menopause, tell them about common symptoms and diagnosis, give advice on lifestyle changes and interventions that could help general health and well-being, then tell them about benefits and risks of treatment for menopausal symptoms, counsel them on long-term health implications of menopause. Explain to women that as well as a change in their menstrual cycle, they may experience a variety of symptoms associated with menopause, including vasomotor symptoms, for example, hot flushes and sweats, musculoskeletal symptoms, for example, joint and muscle pain, effects on mood. They can have low mood, then urogenital symptoms for like vaginal dryness, then sexual difficulties like low libido, low sexual desire. Give information to the menopausal women and their family members or carers about the following types of treatment for menopausal symptoms. Hormonal, for example, HRT. Non-hormonal, for example, clonidine. What else we can give? We can give citalopram, we can give fluoxetine, we can also give them paroxetine. Non-pharmaceutical, for example, cognitive behavioral therapy. Give information on menopause in different ways to help encourage women to discuss their symptoms and needs. And give information on contraception to women who are in the perimenopausal and postmenopausal phase. Offer women who are likely to go through the yes, dear. Yes, doctor. Yeah, yeah. Venlafaxine, yeah. Venlafaxine actually more popular than paroxetine or fluoxetine. Why? Because venlafaxine has both properties. SSRIs and it will also inhibit in reuptake of noradrenaline also. Okay, so that's a good drug. Venlafaxine you can give, and there are not many contraindications. Venlafaxine, actually, this one is covering the NICE guideline, and this venlafaxine was approved later. That's why it's not here. Venlafaxine is a good option. Even when you have to give clonidine, don't give it orally. It's better to offer a skin patch. Okay. Many other things can also be given. It will depend that what exactly is the most bothering symptom. So, offer women who are likely to go through menopause as a result of medical or surgical treatment, including women with cancers at high risk of hormone sensitive cancer or having gynecological surgery. Offer them support and give them information about menopause and fertility before they have their treatment. Refer to a healthcare professional with expertise in menopause. And just remember one thing, that this referral to the fertility specialist is not limited to the women. Even teenage boys, if they are expected to undergo some anti-cancerous treatment, you have to refer them to the fertility specialist. So if you have any confusion, any problems, then you can send them to someone who is an expert in dealing patients with menopause. Then this menopause is going to have short-term symptoms and long-term symptoms. So regarding short-term symptoms management, we will have to see that what exactly she is having, and then we will have to adapt a woman's treatment as needed based on her changing symptoms. One shoe size is not going to fit all. You will have to see what is bothering her and how you can improve her quality of life. So if she's having vasomotor symptoms, offer women HRT for vasomotor symptoms after discussing with them the short term, like up to 5 years, and longer term benefits and risks. Offer a choice of preparation as follows, like estrogen and progesterone to women with a uterus, estrogen only to women without a uterus. So don't routinely offer selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, that will be venlafaxine, or clonidine as first-line treatment for vasomotor symptoms alone. Explain to women that there is some evidence that isoflavones or black cohosh may relieve vasomotor symptoms. However, explain that multiple preparations are available and their safety is uncertain. And different preparations, they may vary. They can have interactions with other medicines, and these things have been reported. Like if you will give like this St. John's wort, it is going to interfere with the platelet function, so it should not be given when your patient is taking aspirin. So then this St. John's wort, it can cause drug reactions also. So you have to remember these things. If a woman presents with psychological symptoms, then consider HRT to alleviate low mood that arises as a result of the menopause. Consider cognitive behavioral therapy to alleviate low mood or anxiety that arise as a result of the menopause. Ensure that menopausal women and healthcare professionals involved in their care understand that there is no clear evidence for SSRI or SNRIs to ease low mood in menopausal women who have not been diagnosed with depression. So someone with a low mood, having depression, low self-esteem, then these drugs have a role. Then many patients, they will complain of altered sexual life, sexual function. So consider testosterone supplementation for menopausal women with low sexual desire if HRT alone is not effective. So you can give them tiburones, okay? Because they will not, sometimes they will give you in the question, give her dihydrotestosterone. Just remember, we have to give them testosterone, but it can be given in the form of tibolone because it has estrogenic, progesterogenic, and androgenic properties. Or you can give them dihydrotestosterone. I mean, anything with the word testosterone, that's going to be the correct answer because they will test your concept. Then it can relieve. So you will have to see, but basically, in the setting of menopause, it is recommended for those who have low sexual desire or sexual dysfunction like that. You should know that these guidelines are developed for those people who have like different setup, they have different lifestyle. So and then otherwise also in the normal human beings, they say that this normal sexual function, it is one of the normal parameters of seeing that a person is feeling well or not. Okay, that's why these things are also important because emotional behavior, how they are interacting, how they have, and how does their support system works. So it is very important for them. That's why they will always ask you questions that she has sexual dysfunction or she has like this low libido. So what should be done? Or they will say that she has hypoactive sexual desire. So you have to give them some any treatment which contains testosterone. So usually they will give you this option of tibolone. Okay. Okay, that's good. So in this age group, the patient they can have urogenital atrophy. So we need to offer vaginal estrogen to women with urogenital atrophy, and including those on systemic HRT, and continue treatment for as long as needed to relieve symptoms. So if she's taking HRT, still you can give her estrogen. Okay, just remember because they have, because the thing is that when you're giving HRT, you are giving them hormones in very low concentration. So they are not going to have like many significant effects on them unless patient has some underlying strong risk factors for VTE or development of cancers. So consider vaginal estrogen for women with urogenital atrophy in whom systemic HRT is contraindicated. So you see, these are important points. Even if HRT is contraindicated, but you can give them vaginal estrogen, and after seeking advice from a healthcare professional with expertise in menopause. They will not give you full option, they will just tell you that she has many risk factors. So can we give her HRT? Can we give her vaginal estrogen cream? So we can give it to her because even if this systemic HRT is contraindicated, you can always give them some estrogen. Very low concentration, and it is not going to cause any significant changes in her health. So if vaginal estrogen doesn't relieve symptoms of urogenital atrophy, consider increasing the dose after seeking advice from a healthcare professional with expertise in menopause. Explain to women with urogenital atrophy that symptoms often come back when treatment is stopped. Adverse effects from vaginal estrogen are very rare. They should report unscheduled vaginal bleeding to their GP. Advise women with vaginal dryness that moisturizers and lubricants they can be used alone or in addition to vaginal estrogen. So don't offer routine monitoring of endometrial thickness during treatment for urogenital atrophy. So if your patient has dryness and you want to give them some lubricant, so what type of stuff you would like to give her? Don't offer her petroleum jelly or KY jelly. Just say water-based lubricants. They are available with different combinations, but my reference is strategy. Give them water-based gels or lubricants. Okay. Then what about complementary therapies and unregulated preparations? Tell them frankly that efficacy and safety of unregulated compounds is unknown, and We don't know about their, like, they are bioidentical hormones, so we don't know much about them. Women who wish to try complementary therapies, that quality, purity, and constituents of products may be unknown. Advise women with a history of or at high risk of breast cancer that there is some evidence that St. John's wort may be of benefit in the relief of vasomotor symptoms, and there is uncertainty about appropriate doses, persistence of effect, variation in the nature and potency of preparation, potential serious interactions with other drugs, including tamoxifen, anticoagulants, and anticonvulsants. These three things should be on your fingertips. Tamoxifen, anticoagulants, all antiplatelet agents, aspirin, heparin, warfarin, and anticonvulsants. Like in the epileptic patient, you are giving them everything. Then review and referral. Discuss with women the importance of keeping up to date with nationally recommended health screenings. Review each treatment for short-term menopausal women at 3 months to assess efficacy and tolerability. If you have given her some treatment, then you should see how she's doing. Annually thereafter, unless there are clinical indications for an earlier review. For example, if she thinks that her symptoms are persisting and they are ineffective, or she's experiencing some side effects or adverse events have occurred. Refer women to a healthcare professional with expertise in menopause if treatments do not improve their menopausal symptoms or they have ongoing troublesome side effects. Consider referring women to a healthcare professional with expertise in menopause if they have menopausal symptoms and contraindications to HRT, or there is uncertainty about the most suitable treatment options for their menopausal symptoms. Another important issue is related to starting and stopping HRT. Explain to women with a uterus that unscheduled vaginal bleeding is a common side effect of HRT within the first 3 months of treatment, but should be reported at the 3 monthly review appointment or promptly if it occurs after the first 3 months. Offer women who are stopping HRT a choice of gradually reducing or immediately stopping treatment, and explain to them that gradually reducing HRT may limit recurrence of symptoms in the short term. Gradually reducing or immediately stopping HRT makes no differences to their symptoms in the longer term. Short-term symptoms, they will reoccur. Long-term, they will not reoccur, whether you stop abruptly or you stop it gradually. If you take history and women is found to be at high risk of breast cancer, give them all information on available treatment options, information that SSRIs, paroxetine, and fluoxetine should not be offered to women with breast cancer who are taking tamoxifen. They are on tamoxifen, no SSRIs. Okay. In short, refer to a healthcare professional with expertise in menopause. So don't treat it yourself. If they don't give you this option that refer to the specialist, then make sure that you don't offer them SSRIs like paroxetine, fluoxetine. What are long-term benefits and risks of HRT? VTE. Explain to women that the risk of VTE is increased by oral HRT compared with baseline population risk. The risk of VTE associated with HRT is greater for oral than transdermal preparations. The risk associated with transdermal HRT given at standard therapeutic doses is no greater than baseline population risk. Consider transdermal rather than oral HRT for menopausal women who are at increased risk of VTE, including those with a BMI over 30 kilograms per square meter. Consider referring menopausal women at high risk of VTE, for example, those with a strong family history of VTE or hereditary thrombophilias. Refer them to a hematologist for assessment before considering HRT. What is baseline population risk of developing VTE? 5, 2 per 100,000 or 5 per 100,000? Okay, so if they will take, yeah, so if they will take in the postmenopausal period, if they will take HRT, so how much their risk will increase? Yeah, actually the older figures were like baseline risk is 5 in 100,000. If um, they will be like immobilized, then the risk will increase to 12 per 100,000. If they are taking HRT, it will increase to 30 per 100,000. If they are taking low dose combined oral contraception, then it will increase to 15 in 100,000. And if she's having pregnancy, and then she has opted to use combined oral contraception in the same year, then the risk will increase to 60 in 100,000. So her risk of developing BTE will increase tremendously. They will not give you exact figure, they will give you the figures around the same figures. Okay. So cardiovascular disease. Ensure that menopausal women and healthcare professionals involved in their care, they understand that HRT does not increase cardiovascular disease risk when started in women aged under 60 years. It doesn't affect the risk of dying from cardiovascular disease. Be aware that the presence of cardiovascular risk factors is not a contraindication to HRT as long as they are optimally managed. They can have familial risk, but then lifetime, many things can be there, so you have to give the cumulative risk. Inform the women that the baseline risk of coronary heart disease and stroke for women around menopausal age, it varies from one woman to another according to the presence of cardiovascular risk factors. HRT with estrogen alone is associated with no or reduced risk of coronary heart disease when estrogen is there. HRT with estrogen and progestogens is associated with little or no increase in the risk of coronary heart disease. That's all you need to tell them. So estrogen is going to be protective. Explain to women that taking oral but not transdermal estrogen is associated with a small increase in the risk of stroke. Also explain that the baseline population risk of stroke in women aged under 60 years is very low. So as the age will increase after 60 years, the men and women, they are going to have the same risk. Then about type 2 diabetes. Explain to women that taking HRT either orally or transdermally is not associated with an increased risk of developing type 2 diabetes. Ensure that the women with type 2 diabetes and all healthcare professionals involved in their care, they are aware that HRT is not generally associated with an adverse effect on blood glucose control. Consider HRT for menopausal symptoms in women with type 2 diabetes after taking comorbidities into account and seeking specialist advice if needed. Regarding breast cancer, explain to women around the age of natural menopause that the baseline risk of breast cancer for women around menopausal age varies from one woman to another according to the presence of underlying risk factors. HRT with estrogen alone is associated with a little or no change in the risk of breast cancer. Little or no change. Okay. HRT with estrogen and progestogen, it can be associated with an increase in the risk of breast cancer. Combined one, it is going to increase the risk a little bit. Any increase in the risk of breast cancer is related to treatment duration and reduces after stopping HRT. Estrogen alone, no change, or it will reduce the risk. But combination therapy, it is going to increase risk. Osteoporosis, you should counsel the women that baseline population risk of fragility fractures for women around menopausal age in the UK is low and varies from one woman to another one. Explain to women that their risk of fragility fractures is decreased while taking HRT and that this benefit is maintained during treatment but decreases once treatment stops. It may continue for longer in women who take HRT for longer periods of time. So what is the effect of HRT on dementia? This is unknown. Likelihood of HRT affecting risk of dementia is unknown. What about loss of muscle mass and strength? So explain to women that there is limited evidence suggesting that HRT may improve muscle mass and strength. Muscle mass and strength is maintained through and it is important for activities of daily living. Like they need to do some exercises to maintain their muscle mass, like weightlifting, that is important for toning up your muscles. One special area is diagnosing and managing premature ovarian insufficiency. You're going to get questions, one or two questions on this topic also. How do we diagnose premature ovarian insufficiency? Take into account the woman's clinical history, for example, previous medical or surgical treatment, and family history when diagnosing premature ovarian insufficiency. Diagnose premature ovarian insufficiency in women aged under 40 years based on menopausal symptoms, including no or infrequent periods, like taking into account whether the woman has a uterus, and elevated FSH levels on two blood samples taken 4 to 6 weeks apart. Do not diagnose premature ovarian insufficiency on the basis of a single blood test. Do not routinely use anti-Mullerian hormone testing to diagnose premature ovarian insufficiency. If there is doubt about the diagnosis of premature ovarian insufficiency, refer the woman to a specialist with expertise in menopause or reproductive medicine. Then how do we manage premature ovarian insufficiency? Never use this word premature ovarian failure, especially during OSCE. Make it your habit to say premature ovarian insufficiency. Offer sex steroid replacement with a choice of HRT or a combined hormonal contraceptive to women with premature ovarian insufficiency, unless contraindicated. For example, in women with hormone-sensitive cancer. Explain to women with premature ovarian insufficiency the importance of starting HRT, of starting hormonal treatment either with HRT or a combined hormonal contraceptive and continuing treatment until at least the age of natural menopause, unless it is contraindicated. Because this is the shortest duration for which she should take it, and then if she is having postmenopausal symptoms, then we will have to give HRT. We will have to give for longer periods. And then tell the woman that baseline population risk of disease such as breast cancer and cardiovascular disease increases with age and it is very low in women aged under 40. Tell them that HRT may have a beneficial effect on blood pressure when compared with a combined oral contraceptive. So which one is a better option if they give you both? HRT. When she has some problem with the blood pressure, you cannot give COCPs then, but you can still give them HRT because they contain very low dose of hormones. Tell the woman that both HRT and combined oral contraceptives, they offer bone protection and HRT is not a contraceptive. Give women with premature ovarian insufficiency and contraindications to hormonal treatment advice, including a bone and cardiovascular health and symptom management. Consider referring them to healthcare professionals who have the relevant experience to help them manage all aspects of physical and psychosocial health related to their condition. So that's all you need to know about menopause. Any question, any problem? Okay. Yeah. If she's taking only this estrogen, let me go back to that one, that then her risk will not change, or it should drop slightly. Okay. You want to know about the cardiovascular side effects. Okay, let me read that one for you. And you didn't ask me that question, that does it have any effect on risk of developing cancers? Okay. You will tell them that HRT, it doesn't increase cardiovascular risk when starting in women aged under 60 years, and doesn't affect the risk of dying from cardiovascular disease. So you have to see that what are, does he have any risk factors for cardiovascular disease, and she doesn't have a contraindication to HRT. So if she is taking HRT with estrogen alone, it is associated with no or reduced risk of coronary heart disease. And HRT with both estrogen and progestogens is associated with little or no increase in the risk of coronary heart disease. Estrogen will either decrease or no change. And this, when you are giving combination therapy also, still little or no increase in the risk of coronary heart disease. So she can take both forms safely. But the risk of stroke, like a bleed in the brain, it will increase. He can have paralysis. So is it clear now? Yeah, it will increase stroke. CVA is also correct, but she can have a hemorrhagic, or she can like have, if she has other risk factors, she can develop this occlusive also. So hemorrhagic or ischemic, any type of stroke can be there. So is it clear? Okay, that's clear. Any other question? Anything? Yeah, yeah, let's go back to that point. All of these, if you will go to this topic, each paragraph, it will answer certain questions, because in the exam you have to decide, and the things are clear, but you have to remember so many things. So you will tell them that her risk of developing cancer actually depends upon the presence of underlying risk factors, and like if she has a family history, that is important. If you're giving them estrogen alone, it is going to decrease the risk, or it will have no change. But if you are giving them combination therapy like estrogen and progesterone based HRT, it is going to increase the risk of developing breast cancer. Combination therapy, it will increase the risk. And it is also related to this combination. Then the treatment duration and the risk will reduce after stopping HRT. Is it okay? So you will find this topic on web page also, and then it will be easy for you to read from there, and try to read these topics today, because if you are reading on the same day, so since the things are fresh in your mind because we just discussed them, right? So then it is easier for you to retain this information. Okay. So yeah. Yeah, yeah, I am because as a policy, we discuss menopause and osteoporosis together because many things are related, and students they will have confusion about their uses, indications, contraindications. So that's why better to discuss them together. So, I need to stop this meeting for just 1 minute because, I don't want the videos to be very long because then it is easier for you also to find the topics, right? So I will just close and log in 2, 3 minutes so you can have a bathroom break or you can go and just grab a cup of coffee. Okay, so we'll be back. Okay, dears. See you in a moment.